Kia ora e te whānau. It's wonderful to have you all join us. And we're going to run this session really simply. I'm going to ask our panellists to introduce themselves, and then we're going to turn our attention to our wonderful speakers who are just have more than woken up, I'm sure, in Scotland time. We've got 3 fantastic speakers that we'll introduce, and then we'll run the session. So let's kick off. Sam, would you like to introduce yourself, please?
Kia ora, I'm Sam Merton. I am the president of the Royal New Zealand College of General Practitioners. I work as a GP in Wellington and have done a little bit of video consultations, and they've been very entertaining, but mostly use telephone for my telehealth work at the moment.
Excellent, thanks Sam. Alex?
Kia ora koutou. My name is Alex Forsyth. I am the Director of Allied Health Scientific and Technical and the Kairangi, or the Operational Lead for Primary and Community Services at Wanganui DHB. I'm also the co-chair of the Clinical Informatics Leadership Network, and I'm the Telehealth Lead here at Wanganui DHB.
Thanks Alex. John?
Kia ora koutou, ko John Harries, taku ingoa ko Ngāti Ruanui taku iwi. I'm John. I am the Group Manager for Emerging Health Technology and Innovation at the Ministry of Health and Data and Digital. And for my sins, I'm a member of HINS and the Clinical Informatics Leaders Network as well.
Awesome, thanks very much, John. And look, it's an absolute pleasure to have 3 wonderful women joining us from Scotland to share their telehealth experiences with us. And I'm going to let them do some introductions of themselves, but we have got Nessa here, who has got a very exciting title of Knowledge Exchange Manager, which I think is the coolest title ever. I wish I had a title like that. Morag Hearty from the National Strategic Lead of Remote Health Pathways, and then Hazel Archer, who's head of program. So let's whip in, and we'll start with Nessa. Thank you very much, Nessa.
Hello, and thank you, and thanks very much for the invite to speak to you all this morning. We're really happy to get up super early and have a chance to talk to you about what we've been doing in terms of telehealth, but in Scotland we tend to describe it in terms of digital health and care, and hopefully that will become obvious as we go through the presentation. For us it's a wider application and use, and the terminology tries to reflect that. So I'm just going to very shortly give an introduction to what the framework around digital health and care for us in Scotland is. And I thought I would just start, I'm sure some of you are very familiar with this, but give a little bit of context for Scotland. So we have a relatively small population, 5.4 million at the last count. In Scotland we have 14 regional health boards and 7 special health boards. The reason they get denoted as a special health board is basically because the special health boards have a national remit, the regional health boards cover the region. The special health boards tend to deal with things like logistics, data analysis, etc. on a national basis. We have 1 public health body, actually a new refreshed public health body, which just came into being this year. And we have 32 local authorities or council areas. And again, just reflecting that is part of the understanding for us of digital health and care. It's a wider application. So in terms of Scotland as an employer, or Scotland as an area to come and work, which we hope you all want to do, it's one of the, well, probably the biggest employer in the country, although our colleagues in social care would argue that they're pretty close as well. About 140,000 people are currently employed by NHS Scotland across all the different boards and areas. And obviously in terms of accountability, the boards are accountable to Scottish ministers and supported by the Scottish Government, which is where our programme of work originates. So for us, the kind of guiding principle then is the most recent Scottish Digital Health and Care Strategy. This is the 2018 version. And the new version probably will come out within the next 6 months, but similar in terms of the core vision, and the core vision for us derives a lot from the healthcare quality strategy in Scotland, and that focuses on safe, effective, person-centred healthcare. In other words, what that means in digital health and care or telehealth terms is that people should have the expectation that they can use technology to support their health and well-being, to support self-management, to plan, and to be able to access services as they need to. There's a strong encouragement, not least within the last 6 months, and my colleagues will pick up much more on that, to provide services in the home or in community settings as much as possible. So that's the kind of framework and remit for us. This is just a very brief look at the key areas within the digital healthcare strategy. And as you can see, you know, it covers a huge amount of possibilities, areas of work and different priorities that the Scottish Government will see as being very important to the development. And more than the development, really, for us, it's about the embedding of digital health and care, or telehealth, telecare, whichever terminology, depending on where your professional domain is, that you use. So it's about embedding that into normal, routine, everyday processes and practices, and not seeing it as it has been and tends to be in some cases still seen as a luxury, an add-on, or a maybe, rather than an everyday routine tool. And the strategy tries to reflect that position. Just very briefly, the Technology Enabled Care Programme, which is where we come in, Hazel, Morag and I, and we all have different responsibilities. So the Technology Enabled Care Programme delivery plan, the programme has been active for a number of years, but the delivery plan was just came out at the beginning of March, and obviously then everything changed in the world. So some of the plans, which Hazel and Morag will go into in more detail, became very much the centre of attention. Some of the activities which had a much longer span for planning came really into sharp focus. But that said, we have been doing digital health and care, telehealth, in Scotland for quite a number of years now. We have been doing it, as you'll be very familiar, I'm sure, in some ways in patches, some ways in piecemeal. We've relied a lot on project support, and we still do in many ways. You know, there's nothing wrong with that. Good projects can help you prove whether something is actually feasible or not. But we're trying to shift that back towards the mainstream and towards everyday practice. So the current priorities for us around technology enabled care, digital health, telehealth, are to focus on the use of video consultation. Hazel is going to speak to that in much more detail. Remote monitoring, Morag is going to speak to that in much more detail. Mental health is also a really important one for us. The use of telecare, and for us in other areas, you may refer to that as assistive technologies or welfare technologies. For telecare, that's really the work to support people in their own homes. That's more, not exclusively, but it's more about safety, and it's protection and support for people who are frail or vulnerable, yes, who may have a long-standing health issue, but also people who, for example, become at risk of falls and other reasons, or have a life-changing diagnosis. So it covers a range of adaptations and applications in the home. We also want to support innovation and look at new ways of delivering services. And again, like yourselves, although I think you're much further ahead on the COVID curve than we are, supporting innovation can be challenging when you're in a time of crisis, but actually it can also help to bring about some of the most interesting innovations. And then international engagement, which is just me flying the flag for my little bit of the team especially. We absolutely recognise the importance for us to learn from our colleagues within Scotland, within the UK, and certainly within the rest of the world. We absolutely cannot do this at home just on our own without experience from others. And that's really important for us to help shape the way we move services forward. I think it's probably fair to say, Hazel and Morag can agree or disagree, but in Scotland, we would not have seen the level of commitment in terms of policy and strategy that we've had over these years to the use of digital health or telehealth without the opportunity to work with colleagues nationally and internationally and test things out and really figure out, you know, it may be a brilliant idea in I don't know, California, but is it going to work in Lanarkshire on a wet Thursday afternoon in November? You really have to test that stuff out. So we've had a good opportunity to do that. So briefly to mention COVID, it has obviously resulted in a bit of a shift, a refocusing of some work and bringing about some other new areas that we're now starting to get into. The experience in care homes, which was an area we were beginning to look at in more detail, but obviously that's emphasized that we need to do some more work there. And just very finally, my most recent slide, if you like, this is just a couple of weeks old really, this is from the brand new, spanking new programme for Government for Scotland for 2020-2021, which just came out. And as you can see, just one of the areas of emphasis from from the Scottish Government is around the use of technology to enable, to support, to provide access, to help people self-manage. So all the technologies that we talk about really have to be in line with what government priorities are. It sounds simple, it's not always simple, but that's where we're at the moment in Scotland. And Hazel and Morag will give you much more insight into the active programmes of work, and I will hand over to Hazel. Thank you.
My name's Hazel Archer. I've actually been doing video consulting in the health service for a very long time. So I started way back in 2003, when you had to buy a big Tandberg video conferencing unit that was about £20,000, and you really needed to have something that was very difficult to do, patients that were very difficult to move, and to justify that in terms of cost. And for a long time there was we were looking for how do you actually make this cheaper, easier, so that people can do it in their own homes. And then a number of years ago we came across a product called Attend Anywhere, which I'm sure most of you have heard of, given that it's been developed across the water in Melbourne. So the big game changer for Attend Anywhere was that, first thing was, it was easy to use. It just works in a browser. There's nothing for the patients to download. It's easy. But also, more importantly, it follows a clinical workflow. And that was a big game changer, because if you're trying to do a clinic with lots of people, some you're seeing face to face, some on the phone, some on video, then being able to manage your queues, that were in a bit like a sort of call centre environment, is really important. So you can see people, you can transfer them, you can pick the person you want out the queue, rather than having to organise lots of little 10-minute meetings throughout the day. And works on a range of devices. So having the right technology was really important for us. So we started our first contract with them in about 2016, and we thought we had quite a well-running project. Our activity levels were going up, but to be honest, the number of consultations we were doing was a bit of a drop in the bucket in terms of the overall activity levels. And then I love this quote. I presume you guys have heard of Trish Greenhall. She was doing the evaluation for us of the initial project, and suddenly the relative advantage of virtual consultations has changed dramatically, and I think that's a bit of an understatement. So because we already had a solution in place, we were already working with most of the health boards in Scotland. We were given the green light to actually speed up our implementation. And at the start, things that would normally take months happened in days. So we were due to re-procure our contract, we needed to extend our licenses, and we managed to get from, let's do this, to actually having the contract extended to 6 days. Normally these things take 6 months. But having worked on this for a while, we were in a reasonable position that we at least had a reasonable idea of what we were doing. And over that time, we've kind of formalised things a wee bit. So we talk about our sort of 3-step process, which sounds terribly simplistic, and we have tried to simplify it. But the first bit is the technical setup, and that's, to be honest, that's the easy bit. So with the Attend Anywhere platform, cut the firewall changes, make sure you've got the right web browser, webcam, and then in theory you're good to go. So the technical bit is pretty straightforward, as we've demonstrated in how quickly we've managed to set things up. The one on the other side, the individual training, again, that's reasonably straightforward in terms of how to use the platform, and we did drop-in training sessions, but we also set up a section on our national learning platform called TURAS, which has got videos, it's got how-tos, it's got some clinical content. But the reality is that most people can watch a 3-minute video and will know how to use Attend Anywhere. So that's fairly straightforward. And the real tricky bit is the bit in the middle. It's about the service process. And we developed a sort of rapid scale-up program where we would get some folks in a room, we would help them with process mapping, we would do some rapid testing, and at the end of that 4-week program, you've got a guidance note. So that's basically how we have tried to shape that and set it up. And we've very deliberately taken a sort of quality improvement approach to try and get that off the ground. So that's worked really well in the areas that we have supported, but I would have to say that the vast majority of uptake has been people who have just run with this and have got it off the ground themselves. And that's kind of where we started. So week 0 on that graph was week beginning the 1st of March. And I remember the number well because we did 336 video consultations that week. By the time we got to week 15, which is towards the end of June, we were just under 17,000. And what's quite funny on that graph is you can see all the little dips in that sort of almost straight line. And those are where we've had holiday weekends. So the first dip's Easter, the second dip's our May bank holiday. And I think the third dip was just, there was an extra bank holiday at the end of May for something. I should actually put the newer graph on because that number has stayed very high. So we've had a bit of a dip in activity over the summer holidays where it's gone down to about 15,000 and now we're back up at 17,000 again. And that's video consultations per week. So a huge increase from the 336 we had just prior to COVID. In terms of what people are doing with it, this is the bit that I just find is quite mental, in that it's just everything. We have just about covered every specialty here with a variety of things. I'm not expecting you to read all of this. I think there are some surprises in here that I never thought we'd be doing video calling for. So dental, I mean, I can't think of a much more hands-on specialty than dental. Yet we have, albeit relatively small numbers, but dentists using this for adjusting people's orthodontics, for doing dental health work. So that one was a surprise. And there's odd things in there as well. We've got a group that does wheelchair services. So, you know, they'll look at your wheelchair on a video call and advise you how to do some DIY repairs and stuff like that. So a huge range of specialties. Probably of more interest are the sort of top 10. The highest one is general practice. I would say I think this is a relatively low number. I don't think we've cracked general practice yet. And it's more a reflection of just the number of GP appointments that there are every week. And down to the fact that we rapidly scaled up across general practice. The next one down, child and adolescent psychiatry, this didn't really exist on our radar prior to COVID, but with prospect of not being able to see their patients, you know, vast swathes of clinicians have simply adapted their working and come up with new ways to deliver their services. So, and it's not really surprising that mental health features quite heavily in that. So we've got child and adolescent mental health, community, clinical psychology, psychotherapy, psychiatry is probably not that much further down the list. And other, our allied health professionals have also had a real drive to take this up. So physiotherapy is up there. Again, that's one that you would think was, you know, a very hands-on service. But they've managed to adapt the way that they operate with, you know, basically supporting people to, you know, prop up a camera, show themselves walking across the room, and demonstrate what they're doing to the physio. So they have developed a real skill set around how they're providing these kind of appointments. And another one to pick out there is paediatrics. We had small use in paediatrics prior to COVID, and again that has just grown exponentially. And also things like I was talking to the wife of a paediatric orthopaedic surgeon, and his view was that, you know, he's now developed enough skill in doing remote consultations that he will rarely have to actually see his patients face to face, he reckons, because he can do most of it over a video call. And because that's a relatively specialist service, most of these children would have been travelling from the length and breadth of Scotland to see him. So that will have an ongoing impact after COVID as well. So huge range of things going on. It's important to us that we look at what worked and what didn't work. So at the end of our we had a sort of 12-week plan, and at the end of that we had a bit of a sort of brief pause and a think about where we were up to. And it was clear that in order to sustain the work that we had done, we needed a bit of a vision. We needed a steer from our politicians and to figure out what it was we were trying to do, and to coordinate with our NHS boards. We realised that, you know, instead of long meetings and dragging things out, we needed short, sharp interventions and things rather than, you know, talking about it. If we're looking, because we're taking a quality improvement approach, and because it's quite important, you need data. So you want to see what's working, what doesn't work. So we wanted to have some kind of national dashboard, which we've now got. And by taking a small group of people and doing these kind of learning sets, it's important that we disseminate that learning afterwards. So we are gradually building up a sort of a network, a sort of quality improvement network across Scotland about how we share all that and disseminate it. And we need to fix our website because it's a wee bit of a, there's been a lot of things thrown on it since COVID, so we need to tidy that up. So we've kind of got a bit of a plan, a bit of a vision. And I think that one of the key things was to articulate that vision in a nice, easy to read format, but more importantly, to get the buy-in from that from our politicians. So we've spent a reasonable amount of time trying to make sure that we bring people with us, make sure they're on board, and culminated in you know, getting this kind of signed off by our cabinet secretary and getting that political buy-in. And another key element to that was what do our patients and our service users actually think of this. So we could do an entire presentation on our public engagement, but what we did do was manage to get over sort of 5,000 bits of feedback from members of the public. Admittedly, the main survey was online because it's difficult to actually go and physically see people to survey them during COVID in Scotland because of the restrictions. But we spoke to over 300 organisations. We worked with stakeholders, with groups like the Deaf Association and, you know, people with sort of protected characteristics. So there were focus groups, there was one-to-one contact, there were a range of you know, contacts with people, so it wasn't just online. But the overriding thing for this was that people are really supportive of video calling, particularly during COVID, and about 90% of people said that they supported you know, consultations in that way. So it was a really important piece of feedback because quite often it's the people who don't want a video call who seem to shout loudest. But I think the messaging around that is really important, that this is an additional tool that is there for people where they want to use it, where it's clinically appropriate for them, and also where it's, in a sense, socially appropriate, that they've got the technical knowledge and the comfort to actually do a video call. And then I think the last slide for me was really just again about that sort of buy-in, that was the line that managed to make its way into our programme for governance. So we'll now move to a position where Near Me, which is our service name for Attend Anywhere, as the default option that's right for a person, and they're happy to use the service with the aim that all health and care consultations are provided by Near Me or telephone where clinically appropriate. So the benefit of it is definitely being felt. So that's all I have to say, but happy to take your questions at the end, and I'll have a look at the Q&A while I hand over to Morag.
My name is Morag Hearty. I'm the strategic lead for Remote Health Pathways at Scottish Government Tech Programme. My background is from local area. I'm a nursing background way back, and it was just really interesting to see how many people right across New Zealand are linking in here. I had the fortunate, I was able to visit New Zealand a few years ago for a number of weeks, which was lovely. And I'm from a place, I'm calling from a place called Uddingston, better known as the home of the famous Tunnock's tea cakes. So good morning to you all. The Remote Health Pathways is in a slightly different journey from Hazel's experience with the video calling. We have similar issues, we've had similar background to this one, and certainly COVID has made a difference to to that one as well. We renamed our home and mobile health monitoring, because it was a bit clunky, to remote health pathways, because we wanted to show that this is about a pathway of care and how we would carry this forward. Like Hazel, we try to say, what is it? So there you go. And our aim is really to provide people with safe and effective solutions for health conditions. And we see this as perhaps a pre-runner to a video or a telephone consult, or indeed helping the person manage their own health and care after a consultation as well. So it's really as an end-to-end pathway that we're providing here. And we certainly have had really good feedback from our patients and staff alike. However, it's a slow burn at times. People, are slightly still nervous. The clinical governance around it, can be, they can be different opinions on that one. However, like Hazel, we're trying very hard to make this safe and effective. We could see that we've had for a number of years, we've been using a very simple text messaging service. You will know it in the Southern Hemisphere as Nelly, perhaps. We call it Florence. We've got the basic version, I would say. And it is a simple SMS, and we've used this for some years and done some tests of change, tested the concept, had some good results from that, of people liking it and making a difference, but not everyone was quite bought into that at that time. The work streams before COVID for our remote health pathways, we had our Scale Up blood pressure programme. That was £1.2 million, which was invested from Scottish Government last year. And the intention of that was very much with primary care GPs, and really trying to make the 1.2 million appointments that we have for blood pressure appointments only, something of the past. We had a procurement. We had already made aims to, or plans to have a national procurement for a platform, which would be not in the entire solution to everything, but certainly, as that says there, taking the best of our learning, what wasn't working and what could we make better, and look at what available tech was actually out there and could fit for a national platform we could use, similar to Hazel has used near me. However, it would be the only solution there, because at the same time we had tests of change going on, very much bought into proven technologies and a pipeline of innovation, working with our academic colleagues and our industry colleagues. The Digital Health Institute in Scotland, very, very supportive of this and helping us make the right choices, but bringing forward new ideas, really thinking to the future. And I think that's something that we're seeing. And the other one there was about remote consultations, just avoiding that unnecessary appointments if we could have asynchronous consultations and using something different. Our Scale Up blood pressure programme, as I've already said there, we did have 11 partners out of the 14. We're now up to 13. Only one board has declined to join this at the moment for their own specific reasons. We've had a protocol, the pathways that we've put onto Florence, those have been nationally agreed, and everyone uses the same ones. We've managed to get a solution for record integration. That was a real challenge for us. And like Hazel, we produced a guidance pack at that time, but that's also now going to be changed and updated and refreshed, because we have moved on since COVID this year, and all of a sudden there was a great appetite, and that is now becoming clearer as we go forward. For the blood pressure programme, it was very simple. Already said, we're wanting to scale up that large scale redesign of hypertension management. We have 30% of our adults are actually will have hypertension, and the long-term monitoring of that has been shown and evidenced that this will have optimum management of the medication and their condition, leading to the reduction in perhaps some long-term effects of that. And this was something that was almost a no-brainer, and that expression has been certainly used by more than our clinicians, our staff and our patients indeed, who see this as a way forward. So that was where we were pre-COVID. Challenges are the same as what Hazel's explained, and obviously it has also brought the opportunities there. So that clinical consensus, anyone that's working in the clinical field, you can't always get everyone to all agree a clinical pathway, and that can be a challenge simply in itself there. The changing priorities, certainly in the last few months, the peripheral procurement, so making sure we had enough blood pressure monitors, for example. We knew that we needed something with a multi-channel access, not just a simple working on SMS. The development and a Once for Scotland approach, and also building in that resilience that we needed to take this forward for the future. And underpinning it all is evaluation, making sure that we're testing, we're changing, we're moving that improvement project forward. We were definitely taking that methodology on board, learning a lot of lessons from Near Me, obviously, as well. The remote response to COVID, well, I've already said there, lots of new collaborations. We absolutely brought on some new partners into this. We looked at COVID-19, so we had to do something very quickly to actually monitor COVID-19 symptoms. We had their care home residents. Yes, that was a huge challenge for us. We also had, as we went into the recovery phase, elective outpatients. So could we be doing something to support outpatients, the general practice, long-term conditions? And we were able to look at a number of solutions that may be possible and what could we do in the short term, but certainly looking into the longer term as well. We went at the point of procuring our national procurement contract at that time, because that's taken a good while to really drill down to the technical specifications and the clinical requirements we needed. However, because of the COVID, we were given permission from Scottish Government to procure an emergency procurement. So under the emergency procurement rules, and we brought in a platform called In Healthcare. There's many of those in the system, very similar, but they do offer a slightly more flexible and more functionality than the simple SMS, because we realise as we go forward, more and more people will have access to the smartphones, to tablets, to internet. They don't all, just as we've said with Near Me, there are pockets where, like you will have as well, where you're out in the middle of the street, or you may be up a mountain somewhere trying to find a signal. We know this happens. However, we can push against the people who can use this. We have worked with DHI, and we've got something called vCreate for asynchronous monitoring the video of some conditions, and that's really been helpful, and it's been moving into a clinical rather than just what was previously done for sort of virtual visiting in the neonatal unit to video the babies and let their parents see them at any time they wanted to. We have set up clinical advisory groups to specify and guide those pathways and the protocols we're putting on, and that's been really important. And we've had people from right across the spectrum of primary care, secondary care, our consultants, and our senior members of the clinical staff at Scottish Government sitting there and linking in with the public or the professional bodies like the general practice forums and the primary care access collaborative and so on. So after COVID, as I said, we definitely had a lot of collaboration going on here, and we are now looking to that, as I say, very much the modern outpatients and digital healthcare and the diabetes unscheduled care and technology enabled care, all sitting there, all collaborating together now to see what we can actually move forward, because we've gone into a recovery phase, albeit we have got a second wave potentially hitting us at the minute. But we were always with an eye to the future, because our services and our clinicians were saying, yeah, that's fine, we managed to hit the crisis, but what do we do in the longer term? We really do not want to go back to what we've been doing before. And there was a very strong evidence from our managers and from government down saying, do not go back to what you did before. Here's your opportunity to change your pathways. And as Hazel said, this is really going back to process mapping. So what can you change, and not just tacking digital on or technology on to what you've always done, but actually redesigning your services. And I think that's something that's really key in coming out very quickly now. So post-COVID, from that very sort of small pathway we had there for remote health pathways, we are now sitting with a very large programme indeed, sitting there, that emergency procurement to scale up blood pressure. We've got pathways for irritable bowel and ONS, they were already on the system. We've got all of the things there. We're looking at the chronic disease, pre-assessment, respiratory and heart function were our first priority pathways and areas that our professionals and our strategic leads in the board areas, and indeed at Scottish Government, said those were the priorities we had to address. So we're working on pathways for that. And those are end to end, from primary care right through to secondary care, but also the self-management. There's a growing demand, so we were including there the COVID-19 rehab, so not just about monitoring COVID symptoms, but the ongoing problems we know that are happening there. But underneath all of this, we've still got that strategic procurement, and we're about to go out to industry for the final bids that are coming in there, and we will be having demonstrations of that very shortly. The intention of that will be that we will have a new platform early to mid next year. And the transition from the in-healthcare platform, it will be, we've got some leeway on months to do that on the contract, and we have got the intellectual property of anything we've built that we can take with us, and that's part of the contract, is that we can actually transfer and transition across. So lots of other things going on in the remote health pathway programme, the dermatology for remote outpatients, the Dynamic Scot, which is a very high level COPD managed service, the VCreate Neuro, primary care digital consultation, which is some of the online work that some of the GPs are looking at, and a whole programme devoted to digital diabetes, because it was been a bit patchy up until now. And as I say, we're getting to recovery. That's where we're aiming now. It's not just about what we've done in the emergencies, and you will, as you say, have been far down that pathway, but we're now getting to that recovery. Lots and lots of work to do, and we were a very, very small team, and we've now been given some additional support in there, and working with our own on the ground clinicians, whether that be in our COVID assessment centres, our GP hubs, or indeed at the elective outpatients and our pre-operative anaesthetists. Lots of bodies of clinicians, practice nurses, specialist nurses, and indeed our patients. So let's not forget what they are saying. I think that's so important. It's all very well saying we've got this, but does it actually work, and does it help the patient? And like Hazel, we've had really positive feedback from patients saying this has changed their lives, that they're now more willing to do that in some areas, but in some areas for many years we've had patient power going to their GPs and saying, why am I having to make an appointment? Why can I not take this and send it in? And clinicians are now thankfully saying, yeah, that's a good idea. I trust you to be able to take a blood pressure and send me in something that's and not make things more than they are. You're able to look after some of your own condition. Long way to go still, and I look forward to this, and I certainly would be more than happy to share anything and answer any questions, so thank you for that.
Look, that's such an exciting presentation. 17,000 consultations by week 15. I'm really excited by that, and finishing with those points about how important, of course, our patients are in the middle, that we can't go back, and that this is a new normal. We've got a number of questions waiting. Do not be alarmed, because we will go, if we don't answer those. If you've asked a question, we'll go back to our speakers and ask them later. What we're going to do now, though, is we're going to go around our panellists who've been listening avidly, and I know that they're going to have some really interesting questions. So, Sam, can I start with you, please?
Sure. I mean, there's a million things I could ask, because it's fascinating what you've been doing. With the, you had that rapid rise, and you said that there was a little bit of a drop-off in the number of consultations that are happening now, and I know you've got a resurgence of COVID. Is the drop-off more in the community with general practice, or is it more in the hospital setting with the other specialties?
We had a drop-off over the summer holidays, but that was really just a function of people taking time off work, and matches the normal drop-off in activity you would see for outpatients and the like. We're now back up to the same levels we were at the peak of COVID, so it's sort of U-shaped at the moment. Certainly our GP activity has gone down a bit, so it peaked at 3,500 calls a week, and the services have reopened. That's come down a bit to 2,500 calls a week. So as I say, I don't think we've cracked general practice yet. I think there is no doubt that clinicians are happier seeing a patient when they know what they're going to be seeing, because they can make a clinical assessment before the call around, what they're expecting to deal with. So management of long-term conditions, we think, will start to pick up more, because a lot of that had been paused during COVID and are only just starting to restart. But sort of an undifferentiated, no idea what's walking through the door, people are less comfortable with on video. They would probably want to see them face to face. So it does vary from specialty to specialty, and there's no easy answer for that one.
And one other question, if I'm allowed, with your really remote areas that you're dealing with in the general practice setting, is their broadband and their access just as good as anywhere else?
No is the simple answer to that one. The Scottish Government has, however, spent a lot of time and money over the last sort of 5 years on a project called R100, which is to bring high-speed broadband to 100% of the population in Scotland. So there has been a real shift in people's ability to access not just video consulting, but the whole range of internet services, and they see that as a major piece around supporting rural economies. So things are much better than they were, and you're kind of now down to smaller areas where you've got the farmhouse 3 miles down a track, which doesn't have line of sight to a microwave transmitter and all this kind of stuff. So it's much smaller pockets now than it used to be, but still some issues.
Excellent, thanks for that. Alex.
Kia ora. Thank you all. What a wonderful presentation, and it's wonderful to hear the great work that you've been doing. One of the things that really caught me from the beginning was your patient-centred vision. I think that's absolutely fantastic, and we share here in New Zealand the focus in patient-centred, or here we talk about whānau-centred, which is the family, and the vision to make sure that care that we provide encompasses the whole family. You talked a bit throughout the talk about the need to measure and monitor and talk about outcomes, and we know there are different types of outcomes. There are patient or whānau-centred outcomes. There are functional outcomes in terms of how well someone's doing. There are outcomes in terms of numbers. And with telehealth, which we know is a clinical tool, people can do it well or do it badly. There's also the clinician skill and their comfort with using and the outcomes there. Just wondering if any of you want to talk a little bit about what outcome measures were routinely used and what you saw from that.
I can pick up that from the video piece, and it's a bit awful to say, I don't know. What we have done is that we commissioned the University of Oxford to undertake an evaluation of the service. Now that was last year, and it was published in March, but the fieldwork for that was all done prior to COVID. And funnily enough, the outcomes were, really good system, but it was quite low uptake, in real terms, do all this quality improvement stuff, go off and do this. And, we did learn from that. That's why we're taking a quality improvement approach. But, by sort of May time, you read the report and think, this is just slightly dated now that, our numbers have gone through the roof. So we did actually commission them to do an update, which will hopefully be published in the autumn. So that will arrange a field work talking to clinicians and will hopefully be a good read. The initial analysis is on the Scottish Government website. So if you just Google it, you'll find it. Or I'll see if I can put a link in the chat. In terms of outcomes from patients, there is an opportunity from the platform to actually send someone to a sort of post-consultation survey. So at the moment we've got a national survey, but because that comes up in lots of different clinics, it can't be terribly specific about the outcomes for that particular specialty. But what we have done in our latest version is to put in a validated tool around, do you feel better after your appointment? And I can't remember the name of it, but there is a validated tool in that one that we will hopefully be analysing shortly. That's been there for a month or two now. But there's people aren't forced into our survey. So if they want to do a local evaluation of their own service, they can have their own questions pop up. So there are bits and pieces of local evaluation that will have happened around that as well. But I mean, we now have 16,000 active clinical services. So it's been a bit difficult to actually keep track of them all. So that's why we're paying University of Oxford to go and have a look round and see what's going on.
There's a Morag.
Yeah, like Hazel, we've built in the questionnaire to find out what people think. But we've taken right from the start of pre-COVID, we use an evaluation, the method of contributory analysis, because it's a slightly different setup, because you've got all the different sorts of services and the different aspects of this. Certainly for the scale up blood pressure, what we have shown is almost cost neutral, just simply because, you know, it would be nice to be saying we are absolutely saving money on prescriptions. However, we are diagnosing more people with high blood pressure, so they're requiring, so it's optimum management of that. So we would be saying, oh, it's saving this. However, we do know that there's a long term. We've done some research on this one, carried out by Edinburgh University, one of the professors there, Brian McKinstry, and that's been published as well on the efficacy of telemonitoring. Similarly with tele-COVID, showing that we can actually make a difference if we actually monitor symptoms and get a better outcome, a faster outcome for people. There is that. There's never just one thing that contributes to outcomes, so we're very cognitive of that. You know, watching what's happening, and like that, we've got the evaluation in place to continue that and to carry that one out. I think. Yeah, locally, but the feedback from patients, as you say, and we work with some of the other organisations to make sure that we've got that patient focus, that what we're doing is suiting them, so very much so.
Nessa, did you have anything to add to that?
I would just say in terms of broader outcomes, and I see there's some comments and questions in the chat about uptake and citizen use and staff use and acceptability. You know, obviously these are all important issues, but I'm aware that the wider organisations that we work with, the Health and Social Care Alliance, some of the umbrella organisations who deal with third sector organisations, they're also right now looking at this question with some of their users and service user organisations about how much digital people want broadly, how much video consultation people are interested in. So I think there's been tons of work done, as Hazel and Morag have said, specific outcomes about, you know, service use, etc. But the wider picture about how this might shift the way we use our services, the way we access our services, I think we're still trying to figure that out. I think there's possibly also, just a personal comment, an element of COVID survey fatigue. At the moment, if you use social media, which we do quite a lot to share information, and it's brilliant for that, for our health and allied health and social care staff, housing, etc. But I can't go a day without seeing another COVID survey for carers with people with dementia, people who use primary care, people who have cancer, people, I'm not being flippant, these are all important questions, but I think there's also a question about when and how you ask the question. And are you actually engaging with the service users from the start to try and understand what it is they want, need, and how the service reflects that? Or are you simply throwing surveys at them a year later? So that's my little personal rant on that one. In Scotland, we talk a lot about the Scottish approach to service design. We have a chief designer in Scottish Government, and that's a fantastic initiative. But what it really means in reality is trying to get people who work across services, but in health and care and in digital health, to think about the user first, and to genuinely, and I know Hazel and Morag don't need to hear this and they don't need to hear me say it, but there's really still too much after the fact evaluation. So that's my
wonderful. I think we share that here.
Yeah, no, that's a good reminder. Thanks, Nessa, and thanks for posting those couple of links in the chat as well. John.
Yeah, so question about kind of how closely connected this is to COVID, in the sense that I've been talking to colleagues in the US and Australia, and they've talked about using home monitoring post discharge for patients with COVID, or getting people home in order to keep beds in the hospital for COVID. Are you using telemonitoring in that context? Or is it more an outpatient substitute?
Yeah, so that was something that we looked at very quickly, and we set something up very quickly on the platform we already had, which was Florence, and it was text messaging. However, just at that point, our numbers started to go down. But we were aiming at some COVID monitoring for people who were being seen at our assessment centres, but were not deemed ill enough to be admitted to hospital. However, the evidence coming from across the world at that time was showing us that an early warning, early detection was absolutely essential. So we have got this platform now, and at the moment we're just about to launch this monitoring for patients, which could be used for discharge or to sort of continue to monitor them, but we're also looking at that post-COVID phase as well. So we've got a 2-week window where people will be monitored. The people with the criteria will be given a pulse oximeter, and we'll be looking at their temperature, their symptoms, and the pulse oximeter to try and detect any early warning, and to remind people themselves that not to wait for the monitoring, but to seek some help if certain conditions arise quickly, because we're very aware that as you will all know, that early detection and early treatment can make the difference. So that's where we're at, but we're certainly now looking at that post-COVID recovery, the longer term effects of it, and particularly from our dietetics and our physiotherapy colleagues. So that this will all be work that will go into the pathways that we're putting on this new system at the moment, along with, as I say, some of the chronic disease management, like heart failure and respiratory, where we know those outpatients appointments have been stood down. So to try and actually get people self-managing as well as much as possible. So it's all tied in. So I'm not saying it's not outpatients, it's a whole end-to-end pathway there.
Thanks, Morag. Steve? Oh, we missed the introduction, so you might just have to introduce yourself briefly, Steve.
Okay, hi, I'm Steve Earnshaw. I'm the Chief Clinical Innovation Officer across the 3 Wellington DHBs. So I sort of lead a team of people in Wellington working in IT from a clinical perspective. One of the challenges that we've had with scaling telehealth is that it's not interconnected or integrated with our existing clinical systems, and clinicians therefore find it quite time consuming and quite difficult to use.
So I can...
on integrating what you're doing with your main system.
Yeah, so that's one of the key issues that we've had with all of our telehealth, and it's something that didn't happen particularly for our Scale Up Blood Pressure programme. We did manage to get a system where the reports were generated and dropped into our document, which is our GP systems, so they had a report there. It's been very much one of the requirements of any platform we're using now, to have that open API and to the ability to integrate. We've now got the new platform is able to pull through our National Health Service number, the CAI number, at the first instance, and also the work is well in hand now to be pushing that information from the patient through, and the system through into the clinical portal, where it can then be disseminated out to clinical services, and that information put into notes. So absolutely, one of the deal breakers, quite honestly, is to make sure we've got an integration. Also got a national platform, a digital platform that's going to be acting. We're working with the national services as well. So something there nationally that will be able to pull information through and make sure it's getting to the right clinicians at the right time. So yeah, absolutely.
I would say that questions also came up on the sort of video consulting chat, and actually the answer to that is quite different, because there isn't the same need for integration. So within our patient management systems, there's an appointment type, and that appointment type, there are lots of them, but basically it's either face-to-face, phone or video. And if it's a video appointment, the clinician sees that and then just hops across to Attend Anywhere and looks at the queue and sees the patient sitting in the queue. So there isn't actually the same need to have a high degree of integration. What is important is that the link to the video clinic and that information that's sent to the patient is generated through your patient booking system. but it's just a different way of actually attending an appointment. Now, there is work to integrate some of the EHRs, so that, you know, you don't need to, you know, look from here to here, but it hasn't been a deal breaker for us at all.
Great, thank you.
We're almost out of time, but there's a couple of questions, and so, well, there's actually quite a lot of questions, which I think we'll go back to our speakers and ask later, and put with this recording, providing our speakers are happy and our panelists are happy, we'll go onto the NZTLG website, so www.telehealth.org.nz. But I think we'll allow ourselves to go slightly over time. One of the questions there from Daniel Bennell is about actually how New Zealand's going, and making the comment that it seems like Scotland sustained telehealth during COVID much stronger than we have so far. And I will just say that there is another forthcoming webinar to discuss this, that Health Informatics New Zealand are running on October the 14th. So we won't go into that now, and we'll leave people on tenterhooks to tune in on October the 14th. But what I would like to just ask very, very briefly from our speakers is, just in terms of using a web-based platform that you've built effectively yourselves, as opposed to looking to what we've done, which is incorporate Zoom or Teams or, you know, a variety of different products, Doxy.me within your service. Would you do this again in terms of building from scratch yourselves, or do you think you might go back and just, you know, pull another service in?
Yeah, I mean, in a sense, we didn't build it ourselves, we bought it. So our Near Me is the service name, and we picked Near Me, it was picked by patients because we didn't want to call ourselves something that was a product name, because if we decided further on down the line that it was a better product, a new product, we'd have to rebrand everything. So, you know, we didn't have that issue of having to develop our own thing. We just bought it off the shelf, as it were. But I think there's a real difference between that and the likes of Zoom and Teams. And I think the crux of it is that we've got something which is purpose-built for the use case. And the use case is that you've got a range of people who are turning up at different times for an appointment, which are generally relatively shortly spaced between each other. So if you're setting up a Zoom meeting, you know, we're here at 7 a.m. British summertime to talk to you guys. We've all turned up at the right time. Whereas if that's a clinical environment, then your first patient turns up early, your clinician might turn up late, and you've got this jumble of people who are all arriving at different times. And to be able to try and manage that in something like a meeting platform is actually quite unsustainable, because you end up with lots of different meeting links that you can't keep track of. So it was actually really important for us, for our scalability, that we had something that actually matched the clinical workflow, because it's not just about a meeting. So if your patient turns up for an appointment, the first thing is that they're met by a receptionist quite often. They're receipted into your electronic patient record system to say they've arrived, and they go and sit in the waiting room. They wait for you. You see them. You then decide that they actually go and need to speak to the nurse, the dietitian, whoever else. So you send them, you know, follow the yellow line to waiting area B and sit there till you're seen by the next person. And all of that functionality is built into something like Attend Anywhere, where you can transfer people, you can put them back in the queue, you can bring a third person into the call, for example, a translator, and the clinician is in charge of all of that and that management. So it's a very different use case scenario, which is, you know, the crux of why these things are different. And the one thing I would say about Teams is that we've been looking at Teams for group consultations, but in terms of information governance and usability for patients, it's actually not great. So I would personally don't particularly like Teams for patients for those reasons.
Just to bring in very quickly, we purchased or we had the license for some of our remote monitoring, and then when we decided we needed something different, we did go out to market extensively to find out what was actually there that would fit the specifications and the lessons we had learned, and there wasn't something fit for purpose at that time. So we spent some time actually putting together the specification that we required and the requirements we need, and then went back out to industry to say, this is what we're looking for. So rather than just taking something that someone else decided we needed, we actually said, this is what we want. So we've now gone out to industry for prior information. They have come back with their bids, and there's a certain specification they had to meet, and we're now down to a short list, which I'm not able to share, but certainly will be released fairly shortly, and we'll be looking at seeing what there is there. But certainly we learned the lesson. So slightly different spec from the video conferencing, because there wasn't anything out there that actually did what we needed it to do. So it's been torturous in some ways, but yeah, we hope we'll get something that really is fit for purpose, and also thinking for the future as well.
John might want to say something. John, did you?
Yeah, so Lisa Livingston asked the question about, can we not just have one system in New Zealand? And I suppose the interesting question I've got for Scotland is, do people still use alternative solutions, or does everybody just use yours? And is the thought that you have one solution maybe part of the reason that until COVID, people didn't use your solution? Like, I'm just interested in what choice do people have in terms of the systems they use? Because Zoom's free, I suppose, is kind of where I'm going with that.
Well, Zoom isn't free. It will cut off. In terms of Zoom, I think it's really important that you have a paid account to make sure you've got the appropriate security settings, and I would even suggest an enterprise account so that you can actually force the right level of security and information governance on your calls, particularly if you're using it for group consultations. In terms of the video piece, we already had a programme in place because we've got that sort of political support. We really are the sort of only game in town, and it is the only product in use across Scotland for sort of one-to-one and one-to-small number of video consultations. So we have kind of captured the market a wee bit there, and I suspect some of that is because we were there first. And we already had the programme up and running. But the other bit is, it's because it works. And we've got, you know, the implementation, the training, the process stuff all set up as a sort of a bit of a package that people can see. And also there's been quite a lot of effort made in terms of the sort of education, social media, to get the word out there. So, yeah. I think that's kind of where we are with that. And the other bit is that the health services in Scotland, although we have different health boards, it's not nearly as fragmented as, say, systems down in England where, you know, everybody can do their own thing. And I suppose the last piece is, we bought a national licence for this, and, you know, it's there free to use for clinicians. So the fact that you've got, you know, near me, attend anywhere, which is, there you go, have a free license, we've already paid for it, it's a big driver as well.
A good challenge for you, John. Nessa.
Yeah, I was just going to add to Hazel's reply. Funnily enough, I see Ruth is on the chat, and it's something that we have a call about later this afternoon, you know, whether this kind of top-down approach or the more bottom-up, competitive, multi-system, multi-dimensional approach, which works in terms of sustainability, or which works better. And I'm not sure there is a clear answer, but I would say, just echoing what Hazel said, in Scotland it's been very much a case of the government set the strategy, the applications, the support. If you want all of those things that go with it, you know, you're very strongly encouraged, shall we say, to use that one system. And other systems don't provide you with that level of support and backup should you then need it. And it's also trying to align it, even though we have got lots of gaps in our healthcare information systems and the joined upness of them. I know that's not a word, but it should be. You know, if we want to ever get to that point of having things joined up, then we have to have that element, some element of control over that. But the other side, to your point, John, if you have a system which doesn't maybe as actively encourage competition in multiple types of systems to develop, maybe that does slow down some elements of adoption. I don't know is the honest answer. I can see examples from some of our other international colleagues which have gone a different way. And they've also seen very big peaks and troughs in the last 6 to 9 months in usage. And it hasn't really turned into a sustainable use. I think that's the one we're still wondering what will happen with.
Well, we're actually really are out of time. We've gone a full 8 minutes over. So I think we will actually wrap up now, bearing in mind that we've got a number of questions there to answer. We've got these wonderful folk who we've got up at the crack of dawn to come and talk to us. Thank you so much. And we will go back and, you know, with these questions to our speakers and hopefully steal a bit more of their time in order to do that. Hazel, sorry, you were...
Yeah, I was just very quickly, because I hit the wrong button when I was typing chat things. The 17,000 calls a week is just video appointments. We haven't counted phone stuff. So that was an easy one, so I don't need to answer it later.
Well done. Okay. Well, look, thank you so much, everyone, for joining us. A big shout out, of course, to our mobile health team colleagues who put on these, you know, wonderful webinars, and of course, New Zealand Telehealth Leadership Group. Go and have a look at the website, and we have the HINS webinar also on telehealth on the 14th of October. So go forth and have your suppers, some of us, and for the rest of us, have breakfast. All right. Thank you very much, everyone. Harara.
Thanks for having us.
Thank you.
Bye
Cheers.
now.
Bye.